So our next speaker for the first session, Professor Bill Giard, he'll be discussing status epilepticus management.
Good morning again. So, again, a pleasure to be here. So this talk is status epilepticus. It's going to cover straightforward status epilepticus and then refractory status epilepticus, and then close with some comments about FIRES, which is a bizarre syndrome. So I'm going to begin with some definitions, why status is bad, causes, most of which you know, evaluation, treatment, and outcomes. So 5 minutes is defined as impending status. This is because data published in the 90s suggested that if a seizure lasted for 5 minutes, it was much more likely to last 30 minutes. And that is the time to begin treatment. When I began my training, we waited 15 minutes before treating people for status. Now it's 5 minutes. 30 minutes is status epilepticus, and this is a continuous seizure, or a seizure without so multiple seizures without restoration of consciousness. Established status epilepticus is the failure of first-line benzodiazepine treatment to stop a seizure. Refractory status epilepticus is 1 to 2 hours of ongoing seizure activity, or the failure of 3 medications, 2 benzodiazepines and 1 non-benzodiazepine, to control the seizures. And super-refractory status epilepticus is 24 hours of continuous seizure activity or following the treatment with anesthetic agents. The definitions for what status is also depend a little bit on whether it is absence or focal impaired awareness. Status does many things to the brain. There is increased glucose consumption, so there is the loss of energy substrates. Blood flow is increased and then collapses. Temperature increases. There is an excessive release of NMDA and calcium, which is excitotoxic. There is turnover in your benzodiazepine receptors. There is hippocampal injury, as we discussed in the previous talk, and you can get diffuse brain injury and neuronal loss. And you can, if early in life, you'll have a change in your developmental receptor profiles, which puts you at greater risk for seizures later on in life. So seizures, long-standing seizures are not good for the brain. They kill neurons, and time is brain. That's interesting. This is the most important slide of the talk. I hope you remember everything on this slide. There will be a test at the end. So this is work from Eric Loffman, who is at UVA, demonstrating the effect of status on brain function after time. And the main thing here is that as time goes on, there is effectively a dissociation between the EEG and clinical seizures. And you see changes in energy consumption, metabolism, and excitotoxicity. Oh, well, this is interesting. Okay, so what happens when you seize is there are changes in the expression of your receptors at your synapse. And this is important for 2 reasons. The first is in animals after 15 minutes, but in humans probably after an hour, you get a change in your GABAergic expression in your inhibitory synapses, so that the surface expression of gamma-2 is reduced, and this reduces the efficacy of standard benzodiazepines. And instead, you get the expression of the delta GABA subunit, which is preserved, and that is the target for anesthetic doses of benzodiazepines and other anesthetic agents. So this is why giving regular midazolam or diazepam doesn't work after an hour, and you have to use drips like midazolam. Also, with time, there's an increase in NMDA receptor expression. And this may be why NMDA receptor antagonists, such as ketamine, may become useful after in this setting, shown in this cartoon. There are, of course, other mechanisms. There are inflammatory mechanisms which are increasingly recognized as being involved in this. Part of this has to do with febrile status, but also other febrile and inflammatory processes. You will know the many causes of status, but it is important to at least mention them to you. I find electrolyte abnormalities are particularly common in children less than 3. I am sure they also occur in the elderly population, for whom I do not care. Structural causes, trauma, infectious etiologies. In children, half of status has an infectious or inflammatory basis, so these are very important. Vascular, especially in the elderly. Increasingly recognized are the autoimmune encephalopathies, other metabolic, such as mitochondrial or other disorders of metabolism, and of course always withdraw from things like alcohol or not taking your medications, toxins, and febrile illnesses. When we looked at our new onset status patients, which occurred 11% of children with new onset seizures present with status epilepticus. The average age here was 3.5, a quarter had a family history, and 4% had seizures on EEG afterwards. Imaging established etiology in 30% of patients. So for me, being an imaging person, getting high quality imaging in someone in status is important because it will establish, especially if it's new, it will establish a cause in over a third of patients. This is just the distribution of status in our population, and those, most of these are, half of these are febrile, and those without fever are seen, and that tends to go later on in life. This is just a list of causes. Again, most of these are acute. Some have a remote history of brain injury that puts them at a greater risk for their status, and a large portion remain unknown, which is a third of our patients. But I just want to point out the large portion of inflammatory infectious causes. So this is a very big slide, a very small print of the AES guidelines, which were published in 2016, which is based on a review of all the data which was published. And I'm going to go through this because I think it remains important. So in the first 5 minutes, you stabilize the patient, right? You do ABCs, airway, breathing, circulation, assess the patient, get IV access. And if you have EEG, you get EEG. When you put in the IV, you also check glucose, and you check other electrolytes. And the IV gets the labs and also allows you access to treat. The following 15 minutes is initial therapy, and this is a benzodiazepine is the initial therapy of choice for which there is level A agents. There are a variety of agents that can be used. As Dr. Ching reviewed, it can be midazolam, lorazepam, or diazepam IV, or some form of rectal, nasal, or intramuscular administration of these medications. If you're still seizing after 5 to 10 minutes, you repeat the dose of the benzodiazepine. It is critical to use an appropriate dose of the benzodiazepine. What I find is people use an underdose, and then they use too many doses. That is not effective for controlling the seizures, but it is effective in depressing respiration. So then people get intubated. A common concern is that the medicines will cause respiratory depression. But most people do not appreciate that the risk of respiratory depression with the seizures is greater than the risk of depression with the treatment. You can always open an airway and maintain respirations. So please treat early, treat often, and treat with the right dose of medication. And you don't fiddle to get the IV medication when you have a nasal medication at hand. Okay, after 20 to 40 minutes is the second therapy phase. So you've given 2 doses of benzodiazepine and they have not worked. Then you have your choice of IV phenytoin, IV valproic acid, or IV levetiracetam. Also, I would add to this now probably IV lacosamide. When this was first done in 2016, the ESET study was not published. There are now data to support that and I will get to in a moment, each of these 3 medications is equally efficacious at this point in time. And again, if this is not available, you can use phenobarbital. I would actually say 20 per kilo is probably better. After 40 minutes, you get to the third phase of treatment. And for here, There is no clear evidence to guide therapy. The options are to repeat a second-line therapy with a different medication. So if you use phenytoin, then use either levetiracetam or valproate or phenobarbital. Or the other option is to go to an anesthetic dose of a benzodiazepine or a barbiturate or propofol, which has concerns in children. The data from the SURGE study would suggest that a second-line therapy of a conventional medication, it will be effective in over 50% of the time before going to a drip. Evaluation. So early evaluation with basic labs, as was mentioned, it is, I think, important in someone with a history of status to get an EEG on earlier rather than later. Most people get imaging before their EEG. The EEG should go on if you have access to it within 6 hours of treatment. If you're still seizing by day 2, then you need to do a second level analysis, which includes imaging, serum, and CSF. A high-resolution MRI, epilepsy protocol with and without gadolinium contrast should be done earlier rather than later. Infectious workup, and then immune inflammatory evaluations, which we will discuss. If you look at the Pediatric Status Epilepticus Research Consortium, looking at continuous EEG, so if people with just basic vanilla status, only about 4 to 5% will have continued seizures with monitoring. For people who have more unpleasant status, you will find that 1/3 will have continued epileptic seizures with or without a clinical correlate when they are monitored, and this obviously affects both treatment and also outcome. And of course, if you have ongoing seizures, you are more ill and you stay around for longer. So the Pediatric Status Epilepticus Research Group, the P is silent, so it's SURGE. It's a prospective and descriptive study of clinical practice based on standard of clinical care with no prescribed common protocol of care, although it turns out what we do is pretty similar. And this was a prospective enrollment from 2011 and through about 2022. The criteria were 1 month to 21 years, convulsive seizures, and the failure of 2 anti-seizure medications. What I'm going to report here is some of the earlier data, but the subsequent data have been similar. So 2/3 of our patients with refractory status epilepticus, that means they got through past the first non-benzodiazepine, had a baseline neurologic condition, most frequent some form of intellectual disability, including about 15 to 20% with a history of status. The most frequent causes of status in the pediatric group, which is different than the adult group, is infection-related in 1/2. 80% with refractory status had some form of imaging. 1/3 had stable imaging abnormalities, and 1/3 had new imaging abnormalities. An MRI, of course, detects abnormalities that CT misses. So a normal CT does not get you out of the hopper. CT can be misleading. So MRI is the imaging modality of choice, which we'll hear more about tomorrow. The acute etiology, again, no identifiable etiology in a fifth of patients. 1/2 was infection-related, either systemic infection, fever without identifiable cause, or CNS infection. Blood in the brain is always bad, HIE, medication noncompliance, and electrolyte disturbances. So this is one of the important slides of this talk. So the guidelines and what we've all been taught in medical school has really not changed for a long time. 5 minutes, your first benzo, 10 minutes, your second benzo, 15 to 20 minutes, your first non-benzodiazepine, 40 minutes, your second non-benzodiazepine, 60 minutes a drip. That's what it should be. This is at time 1. The time to the first benzodiazepine was 28 minutes. The time to the second benzodiazepine was 40 minutes. The time to the third medication, which most of the time was another benzodiazepine, not necessarily a non-benzodiazepine, was 60 minutes. The time to the first non-benzodiazepine was 70 minutes. This should be 15 to 20 minutes. And the time to infusion was 3 hours. It should be 1 hour. These are in the best tertiary care pediatric neurointensivist units in the US with top-rate epilepsy programs. If this is what we do at the best places in my country, this is not good for the rest of the world. This is people not treating early enough with an adequate dose of medication and not moving along appropriately. Okay, this is a slide from Nate Cohen's work at my institution, and the main point here is, if you look at the bottom, is the administration of the first non-benzodiazepine was about 40 minutes in our emergency room, and this was impending status as well. But the point here is there really are two populations of status. There's good status and there's bad status, or there's better status and worse status. Some people will stop seizing when they smell a benzodiazepine, even up to an hour of status. Other people, you start giving them the benzodiazepines after 5 minutes and nothing stops them until they get on a drip. So it's not that you won't stop if you're delayed in treating someone, but if you have the bad form of status, you don't know that until you start treating. You should start treating early. And that's also reiterated in this slide. So I showed you the slide earlier on of when benzodiazepines don't work because of the receptor turnover of the GABAergic expression. And that in rats is 15 minutes to 20 minutes, but in humans, on this data, it would be roughly an hour. So after an hour, the non-benzodiazepine, first benzodiazepine is less likely to work, and you'll need anesthetic agents. Okay, we heard a lot of this. So the activity of a benzodiazepine is proportionate to its lipophilic properties. You want rapid uptake and rapid action. And if you have rapid uptake, you tend to have rapid washout. So if you're in status and you give someone a benzodiazepine, you should really get a non-benzodiazepine on board, because the benzodiazepine that works is going to wash out. If you use something like lorazepam, it will stick around longer, although it takes longer to work. We talked about respiratory depression. It doesn't matter whether it's an IV formulation, a rectal formulation, or nasal formulation, which Dr. Ting has gone over. But the important thing is oral medications don't work, and things like clonazepam and clobazam, the uptake is just too long to get in. And the nose is really close to the brain, so that seems like a good place to start. Okay. Established Status Epilepticus Treatment Trial was a landmark study run by Jadip Kapoor at the University of Virginia. So after two benzodiazepines, patients were randomized to phenytoin, which in our country is fosphenytoin, valproate, and levetiracetam. The adult trial terminated early because there was no superiority of any agent. The pediatric study continued. At the end of the day, no anti-seizure medication achieved non-inferiority. That means they were all the same. Phenytoin, 45% stopped, although there was increased risk of intubation and hypotension, which was not significant. And levetiracetam, 47%, one died. But that was not significant. Oh, that seems to be significant, but not here. And valproate, 46% stopped. So the efficacy of these medications is identical. Doesn't matter which one you have, use one of them. If one of them doesn't work, I would use another one. The next study is whether or not ketamine is effective, and that will be levetiracetam or levetiracetam plus ketamine. That was just funded last week by the NINDS back home. So for super refractory status, these are patients who are seizing for more than 24 hours. And of these, out of 281 patients, 31 met criteria for this. And within this group, one had a continuous infusion, two had two, and three or more. So resolution is with various infusions. And almost everyone used midazolam as the first choice of infusion. And this is because propofol, which is commonly used in adults, tends to kill children. They get a really horrible respiratory and cardiovascular syndrome where they can't breathe and their blood pressure drops. So if you use propofol in a child, it should be really for a very brief period of time. It should not be for a prolonged infusion. And half of the patients received additional treatments in addition to the infusion. So if you have super-refractory status, the delayed initiation of the first non-benzodiazepine was significant. So 62 minutes versus 150 minutes. And a delay in a continuous infusion was also present. And prolonged seizure duration was obviously much longer. So the point again is, if you are slow to treat, then you're not going to successfully be successful in treating. And if you don't successfully treat, then it gets increasingly hard to treat. And that might reflect the badness of the cause of the status or the effect of the status on the brain. Okay, so for super-refractory status, the length of stay in the ICU was 17 days versus 3 days. Medical complications, almost 60% versus a fifth. Lower return to baseline function and higher mortality. So in status, has high mortality and morbidity, especially in adults. In children, the mortality is about 2%. And the mortality generally reflects the underlying etiology, which is a little bit different than the adult profile. Okay, the etiology, mitochondrial in 10%, remote symptomatic in a quarter, infectious in 40%, and unknown in a quarter. So a bunch of these met criteria for Norse, although FIRES is probably the better definition in children, and we'll get to that in a bit. So this is the first summary. Early evaluation and treatment, benzodiazepines, 2 doses, non-benzo, second non-benzo, a drip. The second drip, when midazolam doesn't work, is increasingly becoming ketamine. The earlier you use this, the better the outcome. And the third drip that we use is pentobarbital, which has its own issues. But the key factor here is, if you think the child has an autoimmune cause for their epilepsy, such as FIRES, then you really want to avoid pentobarbital because it does bad things to the gut and you can't use the ketogenic diet. You want to use a methylprednisolone or some form of steroid, IVIG plus or minus plasmapheresis. Then after the steroids, you put someone on the diet, and then you use interleukin medications, and anakinra is the medication of choice in this setting. So the principles of infusion are, if you start an infusion, you're going to have something on the patients for when they get off the infusion. So you want to start another medication. We typically use dipyramide in that setting. You titrate to seizure cessation. Once you have seizure cessation for 24, but better 48 hours, you then wean slowly because you'll have withdrawal effects if you're not careful. If the seizures recur, you repeat a cycle. If that doesn't work, you go to the next drip and you do the same thing over again. If you happen to use pentobarbital, you treat to burst suppression to 5 to 7 seconds. Immune therapy, the first-line treatment, you should start within 48 hours. We use pulse IV methylprednisolone for 1 day, and then we taper for 5 days. IV, we send off immune globulins so you don't have an IgA deficiency syndrome, and then you start IVIG. You always get CSF and serum markers for inflammatory agents, and you have to make sure these have been sent off. Then you start IVIG for 2 days. We also screen for HLH, then plasmapheresis, and then we start anakinra, which is within 3 to 6 days of onset of the seizure, and we treat for 3 to 4 weeks. If this is not effective, then there are other cytokine-based therapies that can be used, which are listed here. Other infusions can be used. Valproate can be used. Inhalational anesthetics. Isoflurane is preferred. Propofol, I've talked about. This is very highly effective, but is contraindicated if you've got a mitochondrial disease, if you've got on the ketogenic diet, and you really have to be careful in children. Lidocaine drips. How many people here have used a lidocaine drip? The old school. Okay. There are other agents which are here, ketogenic diet, if you're not in a mitochondrial disorder, hypothermia, and then there's some other things which have been used which really don't work, like anaxolone and Epidiolex. There are rare metabolic conditions that cause status, so always think about pyridoxine, folinic acid, and biotin, especially in young children. And there are advantages and disadvantages to EEG suppression, seizure suppression versus EEG suppression, and each of the medications we have has their own ill effects. So for example, hypotension and respiratory depression with propofol. Hypotension occurs in all of the agents we use for infusions, as does respiratory depression, and some have tachyphylaxis. Ketamine data is not available, but will be forthcoming, but seems to be effective. It's always important to remember the patient has other needs, and you need to have other supportive care fluid, electrolytes, nutrition, positioning, OT, PT needs, ID needs, and so forth. Okay, there are no data that suggest that parachutes are effective. There are no randomized controlled trials. There was one trial, and there was no difference because people were jumping out of a plane that was parked on the tarmac. But So new onset refractory status epilepticus is known as NORS. This really is an adult term. Refractory status in a patient without epilepsy includes infectious and autoimmune epilepsies, has a high mortality rate, usually long-term of impairment in function, and may lead to drug-resistant epilepsy. In children, mostly less than 16, the most common cause of febrile status for refractory status, it is then fires. Usually there is a history of a fever within 2 weeks. And then we don't really see NORS until the end of adolescence. And then it becomes an adult disease with a couple of cases of fires in adults. So fires is considered a subset of NORS, devastating, and febrile infection, nonspecific, high mortality and morbidity. And you have to escalate the status epilepticus medications very quickly. But we generally no longer use barbiturate coma because it kind of gets in the way of the other things we like to use in this. And it's early treatment that is inflammatory is what is effective. And really what has changed, what appears to have changed the outcome is use of anakinra within a couple of days after following the standard conventional immune therapy. I really haven't seen much immune therapy works that much unless it's a clear receptor antibody mediated disease. But the anakinra has improved long-term outcomes and achieved seizure control. So think of post-infectious processes, get CSF, they often have pleocytosis, get cytokines, there's often increase in neopterin. There are some evidence of some genetic changes in some T lymphocytes for people with fires, and there's also a bizarre entity called hemophagocytic lymphohistiocytosis, which may be a microglia-based immune phenomena that is kind of non-specific to various infections that might be the etiologic process for this. So the IL-1 antagonist anakinra, one discontinued because of infection. Earlier initiation seems to be associated with shorter duration of ventilation, a shorter ICU stay, and better long-term outcome. And then there are the other IL-6 antagonists and others that have been used as well. So it is important to think of this early on and should be started within 7 days of onset. And I've already said that many times. So I'm going to close with surgery. So when all else fails, one consider about surgical options, and I don't mean VNS or RNS. So these are children who have an underlying structural reason for their seizures, and they just don't stop. So if you have a clear lesion that is focal that you can go after, then the outcome with surgery may be as high as 80%. And there are a variety of case series that would suggest this with long-term seizure outcome and better developmental outcomes. So you generally have a focal MRI. If you have some form of blood flow study, ASL or SPECT or even PET, you generally find increased blood flow or increased FDG uptake because the area of abnormal cortex or malformation or cortical development is effectively in focal status. And you can know that because of your imaging markers. When you stick electrodes in these areas, they are continuously seizing, even though you can't see that on the surface. Okay. So in conclusion, status is a medical emergency. Time is brain cells. This is dying? Yeah. It's like status, like that thing was about to go. There really is no room for complacency. You can't just say, give them this and walk away. You have to make sure someone gets the medication. You should treat in a timely way and evaluate, as Dr. Ting has said, you have to find the cause because the cause is potentially treatable, and that's what you need to do. So if you've got hyponatremia, all the phenytoin in the world is not going to stop the seizure. Correcting the sodium will. You have to treat with the appropriate dose of anti-seizure medication, and you should do that in a timely fashion. And for the 8th time, I will say a benzodiazepine times 2 doses get to the first non-benzodiazepine by 20 minutes, get to the second by 40 minutes, and your drip should be suspended by 60 minutes. Make no assumptions about care. And there are two populations that seem to be apparent. One is time dependent, and the other, it doesn't matter when you start treatment, they will stop seizing. And I think that gets me to within 10 seconds of the end. There's a small minority who have really bad status that lasts for more than a day. The principal etiologies are inflammatory and infectious. They require extensive evaluation, including high-resolution imaging, and again, aggressive treatment with tiered selection of drips, and when appropriate, auto-inflammatory treatment. You need to identify inflammatory EDIs early because you want to avoid pentobarbital in these populations. You want to initiate autoimmune therapy early, including the ketogenic diet. Surgery is an option for a rare selected few. The mortality in some forms of status may be high, and the outcomes may be poor because you have IAPCO accredited talks. May I have my last slide again, please? And then I can have my silly slide at the end, because if I don't have a silly slide, my life is not complete. Thank you. See? Thank you. Early control thoughts lead to better outcomes, although that's not established, and always think of supportive care. Okay, that gets me to the end, and here's my silly slide, which is the shaggy dog inside of the Stowe Global. Thank you very much. Until tomorrow. Questions? Do you have a question? Stunned silence. There's a question. I missed the first part of the question.
Thank you, Professor William Gaillard. I talked to you before because your name is French, right?
Yes. Mais oui.
Oui. Oui, ma question, c'est autour de la status epilepticus. Do you think there is vulnerability because there is autoimmune and the etiology? Do you have any theory about vulnerability? You know, when you talk in schizophrenia, we speak about vulnerability, stress. Maybe in status epilepticus, idiopathic, there is something about vulnerability to status epilepticus. Do you have any research about that?
So I do not. I mean, obviously, the causes of status are several. And the brain, it's remarkable the brain doesn't seize more often than it does. And I think that there are some causes which are not well understood. I mean, you know, until Dalmau made his publication with autoimmune receptors, that was, and all of us saw these kids with encephalitis, we didn't know what was going on. That sheds light in 5 to 10% of the cases which were enigmatic to us before. There remain a third to 40% of cases which seem to have no cause. They obviously have a cause. It might be genetic, it might be inflammatory, it might be something else. And there are some people who have collected genetic data on these patients. But in order for the genetic analysis to be helpful, you really need thousands of patients, not hundreds of patients. So I think a lot of that work is ongoing, but we do not yet have the results to make us smarter people.
Thank you very much. I enjoy very much this lecture, and I have been to your hospital, the hospital for sick children in Washington, D.C. Many years ago.
Many years ago?
I did, yes, anorexia nervosa research.
But you didn't drop by and say hi to me. There was another question. In the back. Yep.
Short question.
I'll be short.
Thank you for your wonderful lecture. My question is a practical question, more or less. And a lot of our centers, we have no EEG in the ER unit. The algorithm say that from 0 to 5 APC protocol, and should the patient start EEG monitoring?
Yeah.
My question.
Or get an MRI, and not EEG and MRI may not be available.
Not available. Yeah. By the 20-minute, the patient should receive the first-line therapy IV, benzodiazepine or intramuscular or buccal or nasal. Beyond the 12-minute, what can I do? The benzodiazepine induced disturbed conscious level, or the status became disturbed conscious level beyond 20 minutes without EEG monitoring?
Well, I mean, I think you make sure that the patient is stabilized, you have the diagnostic tests off, you check them when they come back, and then you get ready to treat them for if they have continued seizures. You don't wait until the seizures keep on continuing, because then it takes another 5 to 10 minutes to draw up the medication. So to me, you have everything ready, and if someone is still actively seizing after that time, you give them additional medication. It's really, I mean, it's nice to get an EEG on board, but when you're in the busy emergency room, that just is not going to happen. There are people who are looking at portable EEG devices that have sparse sampling of EEG to help people determine whether people who are obtunded are seizing or not. I mean, that's a real problem, because they may be obtunded because they've stopped seizing and they're intoxicated on their medications, and you don't know that. And that's where the EEG is helpful. If you give someone the medication and they brighten up and they start running around the hallways, they're not seizing. So the tough case is where you have someone whose mental status is obtunded. To me, it's better to give a non-benzodiazepine in that setting just to make sure that's not the case. And then if you have access to some form of monitoring, that would be helpful. We can talk afterwards.
Thank you for your lecture. My question is about midazolam. All the texts say it should be given by intramuscular, but in some instances we can see it by direct intravenous infusion. What do you think about the difference?
So I have no opinion. My hospital with Jim Chamberlain used a lot of IV midazolam and IM midazolam to treat status. They did those studies in the 90s and 2000s. They work effectively because they get into the brain very quickly. My concern with using midazolam is it then washes out quickly. So if you're someone who wants to keep on seizing, you need to have a second agent on board. Dr. Chamberlain suggests that's not the case. If you stop the seizures, you didn't have that. When I looked at our data at Hopkins in the 1980s, if you didn't get a second agent on board, you had recurrent seizures. So I just think if you use an agent that's a rapidly acting benzodiazepine in an emergency room, you have to be prepared to not be surprised if the seizures recur. You can use, I don't know if there's any difference between IV, IM, or nasal midazolam. I don't think the difference is probably going to be minimal. But what some people do is, it's going to be easier to get in a nasal medication than to get the IV in. And what the Rampart study showed is that an IM medication would go in more quickly than taking the time to get the IV and to get in the IV lorazepam. So I think you also have to think about what formulation you have and what time is. And it doesn't matter so much what you get in, unless it's like porcelain. As long as you get something in that's effective, getting it in is more important than what you're actually giving. Is that fair, Dr. Ting? Yeah.
In the hands, there's probably a role for the IM, as we talked about, in the hands of the paramedics who are struggling, and IV makes more sense in the hospital, right? Where we're trying to use it more for status epilepticus, refractory status, and so forth.
Yeah, but you can also give an IM dose while you get the IV in. I mean, so it's not if you're having difficulty with the IV access, or there's always bone marrow too. So.
Okay, thank you very much.
My pleasure.
Thank you.
And that takes up all our lunch. So now we go on to the afternoon series of talks,
yes,
right?
Yes.